introduce you, I just realized. So I'm really excited. Mandy's going to talk about the ADP survey. It's a key survey, but I do want to, for those of you that haven't heard, there was $55 million in cuts announced in DDS, part of the 9C cuts that Governor Healy announced. Some of you may have already seen our piece, but it was a briefing this morning with stakeholders, and she reviewed the impact on DDS, 40 million in cuts in residential account, 13 million from a day account, day and employment, CBDS and employment, and then $1 million from children's autism. This amount is part of the $2.7 billion DDS budget. Commissioner Ryder stated that these cuts are projected amounts to be reverted anyway due to delays in placement, getting back to services. No contracts are being amended. Confident that these cuts will not impact people getting back in the next 6 months. Well, we can look at that two ways, which I will editorialize on in a minute. New program development will not be impacted, and they will continue the residential incentives and the new, some of you may have heard about in 2018, we advocated for leveling the service system with supports packages. They are doing what's called service packages. It's a pilot program, and I guess that's not going to be delayed. They may start in spring 2024. However, we are really worried that this news will cause further dampening of people's advocating for themselves who are unserved and underserved, and it's especially affected people with more complex conditions getting back. And so we want to make sure that we encourage people to, basically continue advocating for themselves, and let us know to call the ombudsperson, to call the area director. It's on our website, personal advocacy. And if the ombudsperson, they can blind copy us, whether they're writing to the area director. And we supplied an email for people with this release because we are worried about that. We are worried that, and the other thing, yes, it may not impact the traditional way of doing services, but we are concerned that it's we're still lack of pivoting and things that need to happen for people who are at home, stuck at home. So that's it for that announcement. We can talk about that at the very end if we want. So Mandy, I'm really excited about, you're going to talk about a survey that included over 70, nearly 80 providers across the state, which is a significant portion of your organizations that are providers who are members of your organization. So could you, maybe take the floor, and if you want to show any slides, you should be able to share as well. Up to you how you want to do it.
Sure, I'll share some slides, and it sounds like you all can hear me pretty good, but just let me know if that's a problem. But thanks for the introduction, Leo, and it's great to continue working with you. And it's nice to see so many familiar faces and names on the screen that I have worked with or encountered throughout my time here working in Massachusetts for over the last about 17 years. So let me share my screen and start. Okay. So as Leo had mentioned, ADDP is a statewide trade association that represents our members. Our role is advocacy and education. Our members are community-based providers that offer supports and services to individuals with intellectual and developmental disabilities, including autism and brain injuries across the Commonwealth. So ADDP wanted to better understand the current state of the human services workforce crisis. So we undertook a comprehensive survey of our membership to capture standard metrics related to agency staffing and individuals served. This survey that I'm going to review today is our October or fall of 2023 survey. It's the second in a series of information that we've been collecting every 6 months since the spring of 2023. We're doing this to ensure that we have current workforce data that can also be measured over time. So our plan is to conduct this survey again this spring. So as I have mentioned, our first survey was in the spring of 2023. This most current survey captures a few additional data points as compared to our first survey. So we added turnover rate questions and expanded job titles based on some feedback from providers. So some additional job titles included drivers and community health workers. We contracted with Fraser Consulting to conduct the survey and for that third-party analysis. So we did work closely with them. The programs, that we captured for this survey focuses on staffing and the waitlist information for 6 key residential and day programs, serving individuals with intellectual and developmental disabilities and brain injuries. New to the October survey, we started collecting staffing information for other IDDD programs not listed here, and those we clumped into an quote unquote other category. So as Leo had mentioned, we had an excellent response rate. In October, 77% of ADDP members responded to the survey. This translates to 103 of our members. The response rate increased as compared to our spring 2023 survey, which was 75%, which is still a really good response rate. More than 80% of respondents completed both surveys, so spring and the fall. However, not all who responded in the spring did so in the fall. There was about a 20% variation in the mix of agencies responding. Some follow-up with agencies, some said that they could not respond due to staff capacity and their bandwidth issues. Each DDS region has a fairly even split of respondents. DDS regions are based on providers' headquarters, so they may provide services outside of these regions. But that breakdown is 25% in Central West, 24% in Metro, 23% in Northeast, 27% in the Southeast. And just to give you an idea for agency size based on FTEs or full-time employees, 59, almost 60% of respondents had 200 or less employees, and then 84% had 400 or less employees. So I'll get into the key findings. Our first one, we have 5 key findings that were pulled from the data. The first one is that staff vacancies continue to be high. The overall staff vacancy rate reported was 24%, and this number is down from the spring, which was 26%. This slide shows distribution of vacancies. So throughout the deck, the blue or first bar represents the spring data, and the orange bar represents the fall data. As you can see in the chart, there was a wide variation in the vacancy rates that were reported, with more than 3/4 of respondents reporting a vacancy rate that fell somewhere between 10 and 40%. So for the staff vacancy data, we crosswalked that by the DDS regions. All but one DDS region reported an increase. A decrease in their overall staff vacancy rate. The Southeast region was the only region that experienced a slight uptick. That region was 26% in the spring, and now it's 27%, so it went up 1%. Even with the slight decrease in the other regions in vacancy rates, the current level of staffing shortages still places tremendous pressure on organizations. We've heard they've been utilizing temporary staffing and overtime, which we know is an additional expense beyond or above the state's reimbursement rates for programs. Also, anecdotally, it's not uncommon. We have heard from providers not a part of the survey, but we've heard from providers that they fill the gaps by having managers, directors, executives, all staffing levels step in to cover shifts. So I'll move on to the second finding, which is staff vacancy rates are fairly consistent across service lines, but are most acute in residential. Of the 6 programs surveyed, the greatest number of vacant positions was in ALTR, or adult long-term residential, which is by far the largest of all the programs. The ALTR vacancy rate decreased from 27%, so it went down 1% from the spring, but it still represents more than 4,300 positions. So these 4,300 positions includes direct support professionals, site program managers, clinicians, licensed practical nurses, and registered nurses. You see that the vacancy rate in shared living increased from 22% in the spring to 28% in the fall, and day programs experienced a decrease in staffing vacancy rates. Excuse me, one second. The rates ranged from 19 to 20% in the fall. In the spring, it was between 21 and 26%. So that's good. This chart shows the staff vacancy rates by program. Again, blue is the spring, orange is the fall. As I mentioned on previous slides, the overall staff vacancy rate is 24%, which is down from the spring, that was 26%. Staff vacancy rates decreased, as I mentioned earlier, for day programs. And this chart further breaks it down. They have decreased by 6%, CBDS by 4%, and employment decreased by 2% for their staff vacancy rates. This slide illustrates vacant full-time employees, or FTEs, by program. This is a great visual to see that almost all vacant positions, as I mentioned before, are in ALTR. There are more than 4,300 vacancies there in that program, ALTR. Across all programs surveyed, there are more than 5,700 vacant staff positions. So ALTR takes the lead. 76% of staff vacancies are coming from ALTR across all positions. The third key finding is nursing and direct care positions continue to be the most difficult to fill. LPNs have the highest vacancy rate, reported 33%, when looking across programs by job title or job or position type. It is worthy to note that the LPN vacancy rate declined, though, from the spring rate of 37%. It's now 33%. The DSP position type has the next highest vacancy rate at 26%, and it also decreased from the spring, which was 28%. The clinician vacancy rate increased from 13% to 18%, so that's a 5% increase for clinicians. The case manager vacancy rate increased from 13% to 16%, which is a 3% increase. This slide displays vacant FTEs by position type. As mentioned on the previous slide, even though the LPN position type has the highest vacancy rate for the percentage, the most unfilled position in terms of volume or number is DSP. The number of vacant DSP positions dominating all position types accumulates to more than 5,000 FTE positions. So that's 87% of all positions captured in the program surveyed. As mentioned earlier on the previous slide, the vacancy rate by position type for DSPs across all programs surveyed is 26%, which did decrease from 28% in the spring. It's important to further break down the DSP gap by looking at its impact. Both DSPs, so with the highest number of vacant positions, and LPNs with the highest percentage of vacant positions, are prominent positions in ALTR. So ALTR is the program that was found to have the highest number of vacant positions. This slide shows that more than 3,800 DSP positions are vacant in ALTR. Out of the total vacant positions across ALTR, DSP positions represent 87% of unfilled FTE positions. The fourth finding is on the added survey questions around turnover rates. The turnover rate was most acute among nursing and clinical positions. It was measured by looking at a previous 6-month period. So the highest turnover rate for the 6-month period was for LPNs at 31%, and that was followed by community health workers at 28%, clinicians at 26%, and RNs at 25%. And the 6-month average rate is 16%. The fifth and final finding is the waiting list for day programs shows improvement, but continue to be significant. So the day programs include day hab, CBDS, and supported employment. In the spring, the total waiting list accounted for more than 30% of the pre-pandemic census. So that includes individuals served prior to the shutdown in March of 2020. Data shows that the wait list has since decreased to less than 20% of the pre-pandemic census. It's important to note that the wait list declined at the same time that the staff vacancy rates declined in day programs. These figures show that the numbers waiting for day hab over 1,400, as well as DDS services, day services over 1,200 are waiting. It's assumed that this is a duplicated count, meaning that one person could be counted twice if they're waiting for both day hab and CBDS. These numbers represent wait for the program. So individuals were also counted if they're underserved in the survey, meaning they are not receiving the number of days requested for service. So they may be getting 2 days a week, but requested 5 days a week. So they were included in this count as well. This slide breaks down, I'm going to break down each program for the day services, and this one breaks down the day hab wait list data collected. You'll notice that the pre-COVID census numbers do not match up across the two surveys, the spring and the fall. It's important to note that this varies across this, the surveys, presumably due to the variations in the organizations that responded. We broke the list into the waiting list into 2 categories. So formally enrolled or formally served, meaning they have not returned since March, the March 2020 shutdown, and new referral, meaning they are new to the service after the March 2020 shutdown. So combining these categories, there are 1,470 individuals reported to be on the wait list for day hab. This slide shows the community-based day supports wait list data collected. You can see, as I mentioned before, that the wait has declined from the spring. Combining the formerly enrolled and the new referrals, 890 individuals are reported to be on the wait list for CBDS. And then for supported employment, combining the formerly served and new referrals, 357 individuals are reported to be on the wait list. So we did dig into what are some reasons or could be explanations, and if the data could point to the decline in the wait list for day programs. We could not draw from the data to get one direct positive correlation or reason as to this decline. But we do have some potential explanations that could contribute towards this trend. Anecdotally, after the survey, we did follow up with some providers and they shared with us, so it's not a part of the survey, that they had increased their rates of pay and or hiring and or retention incentives that were already lined up for these programs, regardless of the state reimbursement rates that were either at play or set to be implemented. So it was something that providers had already planned to implement agency-wide at their organization in between the two surveys. We also know that there were rate increases for day hab, CBDS, and supported employment during these two surveys or in between. At the last rate review, CBDS and supported employment programs were projected to increase expenditures more than 14%. Day hab also received a significant investment, a rate increase of 33%. And Mass Health also provided incentives for day hab new admissions and re-engagement from the pre-pandemic levels of attendance. So despite the movement, it's in the right direction. The waiting list that remains still means that thousands of individuals are unable to access services, which places a strain on individuals and families, as well as the residential support system. So these are the participating members who took part in the survey. And that wraps up the findings from our report. It's a lot of information, a lot of different ways to slice the data. Before I pause for questions, I included my email address as well as our president and CEO, Ellen Italiadis's email address. If you think of a question or want to follow up after the session, feel free to reach out to us. If I can't answer your question today, I can follow up with Leo. But again, thank you for the opportunity. I have to say, great job in your advocacy. Everyone on the call and the ARC, we're seeing the needle move in the right direction, and we know there's more to do, and we look forward to continuing to collaborate together.
Thank you, Mandy. That was a great presentation. If you can, I'd love to share those slides with people who attended today. So I took some good snapshots though. But yeah, that was really, you got the message, some of you, that how hard it is to separate the day hab attendance with the CBDS or employment, because people may be a couple of days in one, right? A couple of days. In fact, we used to get some data on that. And I don't think you got a copy of the FOIA that was for both us, both ADDP and the ARC. And there was a lot of questions not answered. So we weren't able to distill from that. You know what I was going to say, you had 4 reasons, that conjecture of why it's gotten a little better. And one might be, well, it just has because of time, but of course, time alone wouldn't be enough. And let me go with a couple of questions people have, but what a thorough, so awesome that you're doing the survey. So I know Giassi asked if rewarding work has been useful for this, relating it to Till I'm assuming Till is still a member of ADDP, and he was wondering if that helps. And I think, my reaction would be, it's just one resource. It's not necessarily, that's a lot of families may go through rewarding work, but most providers go through their own system, right, Mandy, in terms of recruitment and things like that.
Right. So what was the question?
So it says, in 2000, is Till a member of ADDP? In 2018, they joined forces with rewarding work, a worker registry. I wonder if that's helped with their staffing issues. And obviously Till's not here today, but in terms of ADDP, I guess you can answer.
Yes, and so Till is a member and work closely with them, and Daphne is a co-chair on our brain injury committee. So the state was eagerly anticipating, waiting for this survey from EHS to legislators to state agencies. This data has been helpful in our advocacy. And the state has even reached out that they may be taking on, if they do, this may take some time, do a survey of their own. So they've reached out to us around, what we're including in our survey. And so there may be some interest, from them, hopefully to do this and maybe even expand it. But providers are using this too for their own, their own advocacy. It's helpful with their legislators to have this information. So it's been extremely helpful in our advocacy, and hopefully with providers too, in terms of their recruitment and retention.
Kathy Boyle asks, are people who were dismissed from a provider and no new provider has been yet accepted them, are they included in these numbers?
Yes, well, if they're on a provider's wait list, then they're included. So the number could be higher, right? If they're not
Right.
connected to a provider.
And so you're saying probably not included, right? Because they wouldn't be on someone's waiting list unless
Right.
yeah. Or that could be inconsistent too. That could be, some people could have maybe not updated their waiting list too. You don't know.
Right. And then on the flip side, someone could be on two, if there could be cases where
Good point.
an individual may be on two different providers waiting list.
Good point. Okay. Good point.
Yeah.
And then, I don't know if that's Jim, it's JS asking if the 9C cuts, are they part of the cuts the governor was talking about today? Yes, that's the DDS portion. We have to still talk to Mass Health. So again, Mass Health is a deficiency budget organization, so we're less concerned when they get whacked, because if they have people being served. But yes, those were the specific numbers I was sharing that specifically affected Department of Developmental Services. Mandy, one of the things that strikes me is that 26%, right, vacancy rate. And it just seems so low relative to, in a way, relative to the, anecdotal stories I get of what's going on in services. So is it really like, I was thinking about the baseline, like you have, and I'll make life easy by combining two questions. You know how the raw number is clinicians? I saw a number of 33 persons vacant and 202 LPNs, but that's probably based on an underfunding, old budgets that don't really reflect, right, the need for clinicians or sufficient. Am I just blowing smoke here? So it's a combination of the vacancies, even for DSPs, even though it's 26%, it feels like a lot worse. Let me start with that and make life simple.
Right. Yeah, and we thought the turnover rate would be higher too, right? That we've been hearing. And for the providers who couldn't respond because of bandwidth capacity issues, it could have, changed the numbers. Those are the people we need to hear from.
Right. Great point. Okay. That's helpful. That's really
So,
helpful. Yeah.
Yeah. It's not a surprise though with LPNs. We have seen what they have, that they have, part of regulatory relief. They've allowed LPNs to, instead of RNs. So there's been, some changes within the regulations. And maybe it's hard to fill those roles. We've also heard that providers have some providers we've heard have put so much energy and effort into the DSPs. Now it's okay, case managers and directors and clinicians and others are getting burned out. So it's for that, it's not a huge surprise to see that maybe DSPs is a little bit lower than expected, because there's been such big emphasis there.
Great point. Someone's asking, B period is asking, it might be Beth, is there a straight line between pay and incentive increases and lower vacancy staff rates? Or are there other substantial mediating factors? I think you brought up a few. You might want to repeat those, or show the screen if you want.
Yeah, it was hard to pull the, I think this is the slide. The exact, reason why. And we could not from the data pull that one reason, but we do assume that it has to do with a significant investment for Dahab. Now, the 33% is a lot. It's a huge increase. We know part of that is we're just catching up, and that more needs, to be invested in Dahab. And Dahab was the worst across all day programs in terms of the wait list and staff vacancies. So it's great that the state is focusing on this, on that Mass Health is focusing on Dahab. And some providers are doing things within their organization, whether they have the funding from the state to make some changes to hopefully shift that within for staff vacancies. But we weren't. It's still a little early too for the incentives, I think. We had thought, I followed up with some of the providers around, okay, we see that your rates went down for Dahab. Was it because of the incentives? And they said, oh, we haven't billed or implemented that yet, but their rates went down. Well, why did your rates go down? Well, we already had this planned out, hoping that, or banking on, funding coming through. So we see that that's not uncommon. Even for residential, we've seen providers do that, even if they go in the red for some time.
Yeah, and I guess as a trade organization, you want to warn people that because Dahab didn't get a rate increase for what, 6 years, is it, or 4 years, significant amount of time.
A long time, yeah.
Right? That providers who had a mix of services, were taking money, and it's not illegal to do, let's be really clear, from Peter to pay Paul. And in fact, many providers, again, I've said this before, but just to repeat with Mandy here as the trade representative, people also, if they have a mix of services, they may give raises every year. So they're really thinking all the time. And other places do just give raises according to the 257, right, or other rate. I think there's very few that are doing that right now because on the Dahab side, because they hadn't gotten increases.
Right.
So this money is like you said, catch up, right, a little bit. And B, they want to think about next year when who knows what they're going to get. And it's usually a 2-year, right, rate. And as we said, it had been more than 2 years. So it's scary. I mean, it's basically, I had a colleague who I know was paying 20 and change for a position in their Dahab. I think that was for the case manager position. And clearly the rates didn't pay for that. He was doing that,
Right.
to keep the staff on board. And again, that's a median rate. So the census, I was really shocked by that census. I'm shocked every time I see it, right? Because a few years ago, wasn't the number of people in Dahab at 9,000, something like that?
Yeah. Yeah, that number has gone down.
Right.
Right. So I would think I see from the numbers, it looks like, providers and some from what I've heard, their priority is getting people back who were served before, and then tackling, new referrals. Not everyone's doing that. Some brought everyone back. They don't have anyone on the wait list, but those individuals may be getting just 1 day a week.
Right.
But there has been a focus. So, and the data shows that the numbers have gone down more for those that were formerly served, compared to the new referrals.
Okay. And when you get these numbers from the providers, they're sort of basing it on their own benchmark, right? I mean, on their own, they have to report to you. If they had a change, let's say, when they closed down a Dahab setting, right? And they, at that point in time, their census changed. Would they, that could get confusing, right? They may not be reporting that information. Is that fair, or am I making things more complicated than I need to?
Well, hopefully they adjust, their numbers. And so you're saying if someone discharges and they lower their census, yeah, that, is fair.
Yeah.
That could
Okay.
happen.
And because I was looking at, we asked for DDS figures, and they sort of align with what you're sharing. but they're at like 93% for CBDS, right? But again, that's relative to 2020 before COVID, right?
Right.
So people have to, and there's been what, over 5,000 people turned 22 in the interim period. So we're
Right.
really trying to just, I mean, this is why this survey is so important for our field that I can't say enough, because it's at least, it's showing the baseline of what's going on here with organizations. And without that, because we're not getting it from the state, I'm glad the state's asked. And we just need to run with this, and the ARC will be referencing the ADDP study a lot, as well as referencing the minimal stuff we got from, the state agency, at least the census numbers that we got, right? And then trying to figure out, we have a bill that ADP and the ARC support, H-171, that affects both Chapter 257 and Mass Health Day Habits. The only structural, right, piece that actually includes both, because the advocacy through the collaborative legitimately is focused on 257 alone right now. And so that, it's a long shot, the bill, let's be honest, but it is a flag about what's needed to be done. And we're hoping like to have a pricing on that soon, and by using past increments that DDS has gotten. So every time there's a rate increase, right, DDS gets X dollars. And if we can use that to extrapolate what it'll take to get the 75th percentile, we can at least have a figure to report. And when you add day hab to it, it's a lot of money, obviously. But this is,
Right.
anything else people want to ask? Because this is really, I know I asked, like I had 4 questions, I was typing them up. I dropped 2 of them, but it's amazing, because there's even questions about like the case manager, right? You're getting reports, a case manager may be in rehabilitation, they may be in other services, right? And the community health worker, is that primarily in mass health programs, right? That is
Yeah.
prevalent. Yeah. So, I mean, this is complex. This is ADP took on, I mean, really a complex task. And I think it's done an awesome job with it. So I can't say enough about it. But
Thank you. Yeah, we
yeah,
did it because we're hoping, that it helps in our advocacy, and just having the data is so important,
yeah.
and being able to track this over time.
Anybody, last questions? We're gonna, it's actually almost 1:45. My God, we really
I
ran.
told you it wouldn't take us long, Leo. I guess I was off a little.
I'm glad I had the alert to report then. Is anyone tracking where the ARPA money went? So this is again, either Beth or Becky or some other B, where the ARPA money went and how effective those initiatives were. Holy Ghost, that's a good question. I think the second part we're still looking for, but you want to answer that one first, and then I'll follow up.
Well, the ARPA money, there's a few different things here, and I don't have all the, detail in front of me, but it did allow for the salaries, or the rates to increase for FY24 and for FY25 at the 53rd percentile. So since 2019, ADDP, along with the collaborative, which includes some other trade associations in Massachusetts, has advocated that the state use the Mass Bureau of Labor Statistics to benchmark salaries. And so the state adopted that, and then they were pulling the 50th percentile. And for DSPs, they pull, I think it's like 3, it was 4 categories, it might be down to 3 now. They do a blend of that. Then it was the 50th percentile. And then starting the last review for CBDS and supported employment, which was July of 2023, they bumped it up to the 53rd percentile. So our advocacy has been the 75th. So they went up 3 percentage points. So it's going in the right direction. So the 53rd percentile was, close to $20 an hour. And then January this month, for rates that are under review, they went up to 20. Now this is for the average for entry level DSP. And so we're advocating for closer to 22 an hour, which is the 75th percentile. And we're working with the other trades right now to, frame how we're gonna, our ask, especially given what's going on with everything around us with the 9C cuts and just the economic climate. So, but we know too that the 22 isn't enough. So I don't know if there's anything else you want to add there.
Oh, yeah,
Yeah.
so on the ARPA money, what I want to add, which again, wasn't, like you said, it couldn't be annualized. And focusing on the key issues, right? There was a respite initiative. And I can't okay, so we're like a broken record on this, the ARC. So we really felt like that money could have been used to pay a little higher salary, even if it was for only 18 months or 24 months, to do case management at family support centers of people who were unserved or underserved. We also felt like with that money, there could be add-on, at least temporarily, monies for people to do self-direction services, which really require assistance if you're someone who doesn't have a network. Someone who has a network, you get the funding and you can find staff and whatever, believe it or not, because it's like guerrilla recruitment. It's not like an agency recruiting people. We also thought that service coordinators should be reassigned, at least a few at each area office, to focus on the people that are waiting. So like your providers would let DDS know who they are. They would know the people that are most in need. And then DDS, we could have had this pivoting, right, to help people one-on-one, because your providers weren't able to do it because they were trying to get up to speed for the people they could bring back, let alone the transportation issue. So, which was horrible, right, in the beginning of this. It was even worse than I mean, they were both pretty bad, but I'd say transportation at one point was eclipsing, right, the bringing people back. It was being a bigger barrier. Is that fair?
Yeah, it's still an issue. We're, working with Mass Health and DDS on, some potential solutions. Mass Health is going to come out with emergency regulations to allow day hab to transport outside of HST, and
Good.
DDS is looking at running a couple pilots or to test some things to get, folks from their priority is, I think, individuals living at home, but also residences to program.
Yeah, I mean, people, I was in a meeting with 60 families and people who had people in group homes were using the word seclusion, because it was so bad and your providers aren't getting paid for that time. And even to get paid later, all the time is lost for the people at home because they have to be conservative on how they staff the homes. So it's really like Hulu, it's like a bizarre, catch-22. Let me be real specific on the ARPA thing. I just want to say again, what happened was they just asked providers to respond. And when we interviewed 2 or 3 providers that were providing respite, we'd interview them all because we couldn't figure out who they all were. They were not serving people one-to-one. And then one person later said, well, I don't have enough funding to serve the people one-to-one in the respite setting. So those are the kinds of things that I think that is one of the barriers right in the system. There's like a cultural funding barrier. And then, I know there's other barriers that we've been up against. And that includes initially people getting more funding, right, as a provider to bring people back per person when they had one-on-one. So, and that might be getting better now. I don't know.
And I do want to just add one other thing with the ARPA is that there was money awarded for incentives for ALTR for residential, development,
Yep.
and supporting workforce recruitment and retention. So that is still, even with, my understanding is even with the 9C cuts, that will continue.
Yeah, yes. Yeah, that's what we've been told. Yeah. All right. Yeah, this is so we could really, I think this is probably should have stopped 5 minutes ago because we're probably getting really into the weeds now, but we're still in a tough time is the bottom line. The survey documents that there's some improvement and the improvements, we'll just say incremental, to be fair.
Yeah.
And we're hoping and organizations are trying to get back to a good capacity. So thank you, Mandy. Thanks again. This is again, great work. Really appreciate it.
Thank you,
Thank you,
Leo.
everybody. And we'll
Good to
post
see
this,
you.
we'll get the slides and we'll send out the link to the recording.
Yeah, I'll send it to you.
All right. Take care, everybody. Bye-bye and stay tuned.
Thank you.
More
Bye.
sessions. Have a good week. Bye-bye.